the radiological measurements in the patellofemoral joint. So it's not going to be too detailed, just an overview of the measurement parameters that we use currently. I think when I was writing this, I think the first question was, why do we need measurements? We'll commonly see reports with patellar height mentioned, trochlear dysplasia, tibial tubercle offset and rotation. And the reason we measure these is really to give us some prognostic information. You've heard already about the advising patients the redislocation rate. It allows us to plan surgery for them to see how much correction needed and what correction is needed. And really importantly for me, it allows a post-op assessment as well. So you can see where if you've tried to distalize the patella, what height you brought the patella down to. I think the key thing for any measurements is we need consistency to allow comparisons to be made, to allow normal data to be accrued, and for research purposes as well. But as you'll see, there is no ideal method to any of the measurements that we do. So there's a real push now to try and standardize these methods to allow us to develop a normal range of measurements for particular patients, so we can advise them further and plan prognostically and plan surgically. So we're going to start with rotation. And this is really a CT-based imaging. You need to have slices of the hip, of the knee, and the ankle. And the problem with this is not very standardized at all. So for example, if you're measuring tibial rotation, some of the numbers will quote referencing from the back of the tibial condyles. Some of them will measure from the maximal width of the tibial condyles, and vice versa around the knee joint as well, and around the ankle as well. So there's no real set standard that we need, which I think is something we need to develop on to allow us to compare numbers from one study to the next. There are also side-to-side differences. So there's a difference between left and right legs. There's marked geographical differences around the world. So what's normal for Europe may not be normal for somebody in the eastern part of the world. So there's quite marked geographical variation as well as age differences as well. So that as children grow, they will slowly externally rotate. So we need to have an idea for that range of normality for those age groups as well. On average, these are normal, and I say normal with speech marks. The tibial external torsion is around 24 to 30 degrees, and the femoral anteversion is about 8 to 15 degrees. But that's just a variation of normal. I think we also then need to define what your surgical threshold is. So, for example, if somebody's got 18 degrees of femoral anteversion, that probably does not mean you rush in with a derotation osteotomy. So the next measurement we're going to discuss is trochlear dysplasia. You've already heard this mentioned a few times already. And this is the one slice you can do a lot of measurements on. A lot of the radiologists go to town on this in terms of what they can produce. You'll often see things like patella tilt recorded, which is based on the line from the posterior condyles to the axis of the patella. You'll see trochlear depth either measured in millimeters or reference of the posterior condylar line, where you can measure the deepest part, the most lateral and most medial, and calculate your depth. You can do lateral trochlear inclination angles based on the angle of the lateral trochlea in relation to the posterior condyles, and so on and so on. You can measure facet asymmetry. Often the ones that are more lateral facet dominant have an association with trochlear dysplasia. But a lot of these are kind of radiological measurements, and you can add in condylar offsets and anterior trochlear prominence, but they're not really things that we measure regularly ourselves in the clinic and things that we can do much about from a surgical perspective. So I think really that the main classification for dysplasia, we use the de jour classification, which is a combination of an X-ray and MRI or an axial imaging, looking at the crossing sign and spurs on the X-rays. And then you start on the axial imaging from a shallow trochlea, which is a type A flat trochlea, type B, and then type C and D, where you start to get this lateral convexity and the medial hyperplasia and the medial cliff. And it looks very easy to differentiate C and D on those pictures. In reality, in the clinic, it can be a little bit more difficult. But that's pretty much the gold standard classification now for trochlear dysplasia. I think what you should do when you're assessing these patients is assess yourself. You don't have to use a classification system, but you have your own grading system of dysplasia. So you want kind of mild, moderate, and severe. And it's always important to assess congruence of the cartilage surfaces as well, in case you are looking at doing any trochleoplasties. So then on to tibial tubercle offsets, and this is really a radiological measurement of the Q angle that Vishal was talking about earlier. And I think probably the most common measurement is the tibial tubercle trochlear groove offset. So this is an example slice. It's often done by the radiologist where they can overlap the images, but you can make a rough assessment yourself in the clinic. You take the axial slices of the femur and the tibia, where the tuberosity is, overlay them, draw a line along the posterior condyles, and perpendicular to that, you want to calculate the offset distance. And this has probably changed over the years and gradually crept higher and higher and higher. My own personal threshold is at around 20 millimeters, and I'll probably only think about doing something with that if I was doing a distalization at the same time. There is some evidence that it is a CT measurement, and all the numbers are based on CT scans. MRI scans can tend to give you an outline of the cartilage groove, which can differ, and does differ, and I think it undersizes the TTTG by approximately 4 millimeters. So be careful transferring CT measurements to MRI scans. And of course, it can be affected by knee flexion and knee rotation as well, because you're measuring 2 different points on 2 different bones. And if you've got knee rotation occurring, so tibiofemoral rotation, that will increase your TTTG offset. A recent method of trying to tackle that is by measuring things from the same part of the bone. So you've got the TT-PCL distance, which measures the most medial aspect of the PCL. And then again, from the posterior condylar axis, you measure the offset to the tibial tubercle. And this really gives you a true measure of the lateralization of that tibial tubercle. And it appears from the studies that anything around the 20-21 mark and above is increased lateralization. But again, there have been some studies showing that this doesn't quite correlate as we would want it to with instability and symptoms of instability. And the final part is patella height. I think this, as Vipul highlighted, is one of the most important parameters when assessing the engagement. I think it determines what flexion angle your knee is at before the patella engages into the groove, into the deeper groove, which is often not dysplastic once it gets deeper down. It's measured in a number of ways, and we still have no perfect way of measuring. The oldest method is using Blumenstrat's line, so it's taken at 30 degrees of knee flexion. You've got to be careful not to flex it too much because the patella will start to articulate down the femur. And it's only a rough measurement, but you draw a line along Blumenstrat's line, and you want to be seeing how far above the line that the patella sits. Incel Salvati is a calculation based on the length of the patella and the distance along the patella tendon down to its insertion to the tuberosity, which is the blue line on the image. And then you just divide one by the other. It's important you have tension in the patella tendon, so you must make sure you've got at least 30 degrees of knee flexion occurring. And the normal on average is about 1, but there's a spread from 0.8 to 1.2. And of all the measurements, it's probably one of the easiest and has the highest intra-observer reliability. But the problem with it, we talked earlier about measuring post-operative measurements as well. If I was to do a tibial tubercle distalization, as is in the picture here, the Incel Salvati ratio will be exactly the same, even though the patella has been distalized, and that's one of the disadvantages of it. The next way of measuring patella height is to use the Blackburn peel, and this is one I use personally. This is done by drawing a line along the articular surface of the patella, and then you draw a horizontal line along the joint line and a perpendicular from the that line up to the red line that you're drawing where the articular surface meets. And then you calculate the ratio of A over C. And the reason I use this is because it's nice and easy, and it should be around 1. So you'll accept anything from 0.8 to 1.0. Very easy to measure and easy to calculate. And you can see on the pictures on the right, it's a distalization that we did. You can see how that patella has been brought down, and the value of C is reduced from the bottom picture to the one on the top. And finally, on to Caton Deschamps. So this is a measurement using, again, the articular surface of the patella, but it draws it down onto the front of the articular surface of the tibial plateau. And then you calculate a ratio. It's a little bit more difficult to differentiate. You pick out your point on the tibial plateau, and there's a bigger spread in variation of normal as a result. But on average, you want it to be around 1. You can accept 0.8 to 1.0. Again, it's very easy to measure and easy to calculate. And the final imaging, this is the only one that's really based on MRI scans. This is one that Vipul mentioned already, the patellotrochlear index. So you draw a line along the articular surface of the patella, top to bottom, and then start at the very lower aspect and see how much of your trochlear cartilage is overlapping. And you simply calculate a ratio. And you want to aim for around 0.3, so 30% cover. But you can go from 12.5% up to 50%. So if you've only got 12.5%, if it's less than that, that's patella alta. If it's 50% or more, that defines patella baja. And it's probably the only test that really looks at that patellofemoral joint and the articulation of the cartilage surface, which does make it very useful. but still has a little bit of work to do with it because it can be affected by knee flexion. And of course, if your kneecap is subluxed or dislocated out to the side, it can be quite difficult to measure. So those are the ones that we've covered on the talk today. The one of the problems you have with these, if you were to do all of those measurements on each of your patients, you would pick up patella alta in some of the scores, but not all of them. And that's where the problem with reliability comes in. Just quoting Vipul's paper that he showed earlier, this is directly from that, but this is all of the other different measurements of patella height that have been in the literature. So to me, and my reading of that is if there's that many ways of measuring it, there can't be one good way or one useful way of doing it in particular. I think in summary, there are plenty of measurement parameters, but still no ideal way of measuring them. We need to do a bit more work about working out what is normal and how that varies around the world. What's the effect of dynamics, so tensioning up their quads when you take imaging versus static weight bearing and non-weight bearing image. So it's still a fair bit of work to do. But I think probably the best test to measure would be something that's simple, something that's reproducible. I think clinically relevant is really important because if we are going to be making changes or planning procedures, it's got to be relevant to that procedure that we're planning. And it should really be standardized to allow comparison from one study to another and to drive further research. If only it was as easy as getting a standing X-ray. Thank you.